Hello everyone, my name is Dr. Meenakshi and this video is going to help a lot of MRCOG Part 2 and Part 3 students, and the topic is going to be maternal collapse. So we will be discussing about the causes of maternal collapse and also how do you resuscitate or how do you manage a case when there is a maternal collapse. Let's look at the causes. So for the causes, we can remember it by 4H and 4T. So what are the 4H? One is hypovolemia. Hypovolemia can be secondary to hemorrhage. It can be any kind of antepartum or postpartum hemorrhage. And it can also be secondary to neurogenic shock or septic shock. The second H is hypoxia. Pregnant women are more prone to get hypoxic because of the respiratory changes which occurs during the pregnancy. And then we have got hypo or hyperkalemia and hypothermia. The latter, these two causes are not very common these days. And the next one is the 4 T's. What are the 4 T's? The first one is thrombus or the thromboembolism, which is the most common direct cause of maternal mortality in the UK. And the second one is the toxicity. Any kinds of drugs like accidental IV injections of drugs such as local anesthetics or any kind of toxicity with other drugs like magnesium sulfate, which is more common in obstetrics. And tension pneumothorax or cardiac tamponade, which occurs secondary to trauma. And the other causes could include preeclampsia, eclampsia, intracranial hemorrhage, sepsis. All of these would be coming under the causes of maternal collapse. So whenever there is any case of maternal collapse, how do you want to resuscitate it? The first thing that you do is to see whether the patient is responsive or not. And we try to call help and try to call as many hands as possible. We need to have a senior obstetrician, a consultant obstetrician, a senior anesthetist, the critical care team, the cardiac arrest team and the intensivist. All these people need to be in the scene and you need to get as many hands as possible to make sure that you revive the patient. And the first thing you do is to see whether the patient is responsive or not. If the patient is not responsive, then we have to initiate the initial steps, which is the airway breathing and circulation. Although we tell one after the other, everything should be done simultaneously. The anesthetist would secure the airway by doing an endotracheal intubation. In case the intubation is not possible, we secure the airway by either a supraglottic airway or even a back mask ventilation. And then high flow supplemental oxygen, 100% oxygen should be given to make sure that the ventilation is adequate. In pregnancy, because of the gravid uterus, the growing uterus, and because of the diaphragmatic splinting, the ventilation is very inadequate. So therefore, this could be one of the reasons why the success rate, even when we revive in case of collapse, is very, very low, because it is quite challenging. And then in the circulation, we make sure that we have to secure 2 large IV bore cannulas. And in case all of these are being done when you're doing the initial resuscitation steps, always make sure that in the background the cause needs to be found out, whether it is hemorrhage or it is hypovolemia or whether it is because of thromboembolism. The cause needs to be keep running in our minds in the background. So when you find that it is because of hypovolemia, make sure that we pump in the IV fluids. And if the hemoglobin is less than 7, then blood transfusions should be initiated. But if this is a case of a preeclampsia or eclampsia, make sure that the fluid overload should not be done because the patient would be landing into pulmonary edema. So always, before we do any step, we need to always revise and we need to know what the cause could be. And then all of these, each person will be designated each of the function. That is how the entire resuscitation would take place smoothly. And then the CPR should be initiated. And when you see the CPR, it should be done in the ratio of 30:2. 30 chest compressions with 2 breaths. And when you see if the endotracheal intubation is in place, we do 100 chest compressions in a minute and we give 10 ventilations per minute should be performed. And all the chest compressions should be continued until your defibrillator arises. And when you're giving the chest compressions, make sure that the fists are interlocked and these elbows should be straightened, and we give it at the depth of 5 to 6 centimeters in the center of the chest, in the line which is drawn between the 2 nipples. This is very, very important. Because the breasts are engorged during the pregnancy, probably there could be some kind of difficulty when you're delivering the chest compression. And then, until the defibrillator arrives, please keep on doing the chest compressions. And once the defibrillator arrives, then make sure that once you're doing the CPR, you keep checking for the pulse and see whether the rhythm is shockable or not. And placing of the defibrillator pads could also be challenging in the pregnancy. So therefore, we place it lateral to the left breast or over the anterior precordium and the posterior precordium. and the delivery of the current is very similar to what we give in the non-pregnant individuals. It could be in the ratio of 150 joules when it is 150 to 300 joules when it is a biphasic, or 360 joules when it is monophasic. And once you apply this, these could be self-adhesive defibrillators are applied in the pregnancy. And once you do this, you see whether the rhythm is coming back or not. And if it is a not shockable rhythm, then we don't do the defibrillators and we continue with the chest compressions. And in case within 4 minutes of your CPR, if you're unable to revive the patient, then a perimortem cesarean section should be performed. This perimortem cesarean section is not done in the interest of baby, but it is done with the aim to help the mother. And before we initiate all these resuscitation steps, make sure that you tilt the patient to the left side. We can either place a spinal board with a cardiac wedge and place the patient onto the left side, or even a manual displacement of the uterus should be done to the left side in order to relieve the ioto cable compression. All the steps should be done. Before you initiate the steps, make sure that the position would be to left lateral so that we can increase the venous return and the cardiac output. And even after performing all of these, if you're unable to revive the patient, then a perimortem cesarean section is done then and there. All that you need is just one scalpel and 2 umbilical cord clamps. Even if the cord clamps are not available, it is completely fine, because once the scalpel is done, if you're having the scalpel, your job is done. We do a cesarean section and the fetus and the placenta is delivered out. And in case the collapse is occurring after 22 weeks of gestation, make sure that the neonatologist is available in the scene for the neonatal resuscitation. And once the fetus and the placenta is delivered, if the mother revives, then immediately we have to transfer to the operation theatre and give the adequate analgesia, and the suturing of the abdomen would be done in layers and the abdomen should be closed. And in case, unfortunately, if the mother is not revived, then we close the abdomen and we have to record this in the embrace, which is the incident form should be raised, adequate documentation should be done, and everything should be done in detailed steps, like how what all steps were performed and why we were unable to revive, and everything, all of this should be documented in a very clear manner. And then the coroner should be informed, and the debriefing should be done to the relatives if the mother is not revived. And if the mother is revived, then yes, you can debrief to the mother regarding what has happened. So that was regarding a quick review about the maternal collapse. I hope you all found it useful. This is an extremely important topic. I've done my bit by explaining it to you. And please like, share and subscribe to my channel for more of the videos. And I will also link my Telegram channel in the description bar down below. And please do join the channel for more updates. I will see you all in another useful video. Until then, take care and happy studying. Bye.